Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And you know, one of the subjects that you always ask us about is what we call minimally invasive surgical techniques. And part of the conversations that we've had over the last years or so are the issue relative to stents and things relative to GI problems. And so I said to myself, well, why don't we bring an expert? And do I have an expert right in front of me? Dr. Gupta, Dr. Mayuri Gupta, who is a gastroenterologist from Broward Health North. Welcome.
Thank you.
I'm glad you're here.
Thank you very much. I'm glad to be here too.
Good. And to my left is a nurse professional who's in the endoscopic unit at Broward Health North and obviously works with Dr. Gupta and other professionals. And this is Susi Justice, RN. Welcome, Susi.
All right, thank you very much. Thanks for having me.
Good to
It's a
have
pleasure
you.
to be here.
So, Dr. Gupta, tell me what a gastroenterologist is.
Well, gastroenterology is one of the subspecialty of a medicine, and we initially we started being around for basic GI health, and everyone says, what is the gastroenterology? Basically, we consider just like brain, gastroenterology is like a second brain because there are like so much nerve tracts and there is so much going on there. Also, in America, colon cancer is one of the biggest cause of premature death, and it can run in families. It's genetically affected cancer, so the screening is big deal. So everyone at 50 starts worrying about it. So every American knows that they have to mentally be prepared. What is a big thing that comes with being 50?
Susi Justice, if I may call you Susi.
Yes, absolutely.
You are obviously in the endoscopic unit, and you work with people like Dr. Gupta.
Correct.
So tell us what the endoscopic unit is.
Well, the endoscopy unit is at Broward Health North is a place to go when you're having GI issues. We screen people for colonoscopies. We do upper endoscopies, ERCPs, things of that nature.
What are the ERCPs?
ERCP, endoscopic retrograde cholangio pancreography. It's for the diseases of the gallbladder and the common bile duct,
Right.
pancreatic duct. So the patients come to us if they're having these problems to see Dr. Gupta or other physicians of the other specialties.
You see the patient after they are bothered for such a period of time. They have this terrible indigestion. They have problems with constipation, irritated bowel syndrome, all kinds of things.
So we get like all kinds of patients. Some come way early. They have probably no symptoms, and they are the ones that are coming for screening, or their family members have had some medical conditions, and that's why they're coming in. Some patients come in for, they may have, we have various symptoms related to GI tract. They could be heartburn, they could be abdominal pain, bloating, nausea, vomiting, weight loss of unknown reason, anemia, especially iron deficiency anemia, and blood in their stool, diarrhea, constipation, jaundice.
Mm-hmm.
And
they come to you because they're at that point of time where it's bothering or irritating, correct?
Exactly.
And I would assume that both of you would advocate for a opportunity to screen because it's so much easier to prevent what you just said by screening, correct?
Exactly.
So let's just talk quickly about it because we want to talk about the pancreatic stents very shortly. But there are a number of what I would call, I don't want to ever call anything common, but standardized tests that male, female patients should have. So tell me something about the 20-year-old, the 30-year-old, the 40-year-old that needs to be screened.
There are some very young patients that may need to be screened. Those are patients who may have a family history of colon cancer or pancreatic cancer. There are certain genes that run, and there are families called FAP families that are familial adenoma polyposis syndromes, and there is a Lynch syndrome. These are both associated with the colon cancer gene, and they're both predisposed to earlier and more aggressive kind of cancers.
And also, I understand that that a lot of, because we did a show on breast cancer recently, and that the BRCA2 shows up also indicating other gene modifications that are involved in GI cancers, correct?
That's correct. So the Lynch syndrome has one of the other cancer they can have is a breast cancer, and the patients with any other cancer in general, breast cancer, endometrial cancer, are also predisposed more to the other GI cancers like pancreatic and colon cancer. So they need an extensive history and a workup. And if there is any earliest sign, they need to get the tumor markers done. Those tumor markers can be done in blood as well. But they do not replace for screening colonoscopy or screening for pancreatic cancer, which is a little differently done.
Okay. So, Susi Justice, people come in and they come in for multiple screenings. A lot of people don't do screenings because they think it's they don't like the preparation,
Right.
et cetera, but things are so much easier today. So let's talk about some of that.
They are. Well, as we said, people need to be screened for colon cancer at 50 or earlier, depending on their family history, and that's obviously up to their doctor. The preparation, in my opinion, and many of the patients' opinion, is the worst part. A lot of people are nervous about having a colonoscopy for obvious reasons. They're embarrassed, but it's really, really very important to have it done at 50 or before. Like you said, prevention is the key. I mean, it's the day before they can have a little bit of clear liquids. They do their preparation. They have nothing to eat or drink after midnight. They come in early in the morning, usually to see us. They go into same-day surgery in our hospital, and they're prepared IV and seen by anesthesia. We have a great team at Broward Health North in the same-day surgery unit, the anesthesia unit, the endoscopy unit. We all have multiple years of experience. The MDs are great, so people really don't have that much to be nervous about. They're asleep for the whole procedure. Most of the time they wake up and say, "Oh, are we done? Are we done?" And a lot of times the patients will wake up and say, "Oh, let's do that again," because it's not as bad as they think it's going to be. So,
That's important.
yeah, it's very important.
I think the stigma of the preparation has denied a lot of purposeful screenings, and that's sad because it really is not as difficult as it used to be.
No, it's not. And you see people come in, unfortunately, 10 years later and say, "Oh, they didn't want to do the prep," and bad things have happened, and that could have been prevented if they had just gone and done a simple preparation. So, people are embarrassed, but there's nothing to be embarrassed about. And at the hospital, we have a great team, and we make them as comfortable as they can possibly be. There's virtually no pain involved, and it's really, really a good thing to have done.
No question. Dr. Gupta, let's talk about pancreatic disease. Tell us in an oversimplistic way, because the viewers may not even know what the purpose of the pancreas is. Tell us about the pancreatic syndromes, and tell me why I guess you could say the element of your talents of using stents and otherwise are necessary.
So basically, pancreas is one of the organs that help you digest fat, and also it produces certain hormones, especially insulin. So when there is a pancreatic insufficiency, you don't have any ability to be able to digest fats, and you may need a pancreatic enzyme replacement. And if the insufficiency is significant and you develop diabetes, that would be insulin-dependent diabetes. So those are the things that happen with pancreas. Pancreas deficiency can be either one of the, can be genetic too. There are certain syndromes wherein that can happen. There are, whenever the pancreas is inflamed, we call pancreatitis. So that's one of the very common diseases that we see. The most common two reasons why pancreatitis happens is from alcohol and gallstones. Those are known, and there are other several causes. There could be medications causing, there could be viral illnesses causing, there could be disorders like high triglycerides that can cause. So there are many other uncommon reasons, but top ones that we like to remember are the gallstones and the alcohol. So coming to pancreatitis, pancreatitis can be acute or chronic. When people develop chronic pancreatitis, they can develop the pseudocyst. And a pseudocyst basically is not a true cyst. That means that it's not arising from the pancreatic cells, it's coming on top of the cells. So these pseudocysts, when they form, and they can become very large in size. And we've had some patients which were like 16 centimeter size or even bigger. And those are the patients that do benefit from these special stents, which we put it endoscopically through endoscopic ultrasound. So we have it's not that new of equipment, but it's fairly new in terms of a technology being like a decade or something, and the endoscopic ultrasound. And we go in again through the mouth and look inside. We have a special equipment which can take images through the ultrasound, and then we can see the shadows of the pancreas. We identify the cyst or so-called pseudocyst, and depending on the good location, we can leave the stent in, and the stent basically connects through the stomach and that pseudocyst, and it drains internally instead of draining it externally. The external options would be to drain it percutaneous. That means the radiology may have to put like a stent through the skin, going in and leaving like a drain. And the complications from that would be like a fistula formation, infection, and it would be considered still more invasive. The other options would be surgical options, which would be taking away part of your pancreas. So again, comes to the minimally invasive procedures.
Well, you know, our viewers are very, very interested in minimally invasive surgical techniques. You know, I always say that, you know, with every health subject that we talk about, it really comes from the viewers. I mean, they tell us they have a problem, that they heard about something, whatever. Would you mind getting some people to talk about it? But the three top issues are cancer, heart disease, and the issue of minimally invasive surgical techniques. And just thinking about Broward North, you've gone through a metamorphosis. You've created enormous new surgical suites, new multidisciplinary surgical units, and it must be exciting for somebody like yourself working in an environment like that.
That's very true. When after my training from Pittsburgh, when I moved to South Florida, that's when we got that new equipment for the endoscopic ultrasound, and that was really exciting. For myself, I was the only physician doing it.
Both of you who are working there, and I've already heard it from you, Susi, that the importance of the environment enables the staff that are quality people to be able to function in what I would call a more excellent, prevalent way. In other words, they know what they can do, but without having an environment where you have all of this new technique, new procedural areas, you have the interdisciplinary opportunities. If something happens in a complex surgical suite, you know, Dr. Gupta or somebody can call a colleague in to do X and Y. And then, of course, you have trained people like yourself that have had some years of work, even though you're a little girl. I mean, the bottom line is that that I'm sure that you have seen over the endoscopy unit these huge changes over the last decade,
Tremendous
correct?
changes. Yeah, I've been in the unit about 10 years, and it's incredible how far the technology has come. And then when Dr. Gupta got on board, starting the endoscopic ultrasounds and now the stents, it's very exciting. It's interesting and exciting, and it's so great for the patients because, like you said, they're afraid of the blood and the cutting, and these, particularly the stents we're going to talk about, is fantastic. We had a patient that came in, and Dr. Gupta will get more into the procedure and follow-up, but she had the stent placed, and she came back for her follow-up for the stent removal, and she was doing wonderful. She was so excited. They took the stent out. She wanted to take the stent home. That's how good she felt. She felt so much better because, like Dr. Gupta said, when they have these pancreatic pseudocysts, there's the nausea, the vomiting, the pain involved, all the things. Their whole life is altered by this disease process. So what they're doing with the stents has just been incredible for the patients, and they're recovering. Like you said, minimally invasive is the key. It puts their mind at ease, and they know that they're not going to have a long hospital stay. The patients come in the morning. They get, like I said, they get them ready in the morning. We have a great staff. We try to educate them, reinforce what Dr. Gupta has told them and taught them about the disease process. And they come in maybe an hour and a half before the procedure. The procedure isn't very long at all. What do you say, Dr. Gupta? About half an hour, 45 minutes?
Yeah.
So
Typical.
yeah, and then recovery, they go to recovery and go home the same day, and it's wonderful.
So, Dr. Gupta, you got the setup here. You got Susi Justice, nurse professional, just setting it up for you. So talk to us about the stents.
Okay, so in a process of pancreatic or biliary processes, so in case if we talk about pancreatic cancer, so usually the presentation would be the patient would come jaundiced and they may need a stent in the bile duct. So that's typically done through the ERCP. Typically my husband in the practice actually does all the ERCPs. He go in through the same track, like a GI track, and puts a tiny stent in the bile duct, and those patients are relieved from jaundice in next couple days, and then we decide whether or not they are surgical candidates. For the pancreatic stent per se, these are typically for the pseudocysts. They are not for the cancer patients. We are doing it so that we can drain the cyst instead of draining percutaneously or doing it surgically, which is called cyst gastrostomy, which is a kind of invasive surgery. And since this new stent came in, it's kind of like not an option unless if there is some kind of multicystic pseudocyst, which would be like there are several different pockets instead of one large pocket. In that case, you would want to have to undergo the surgery. Otherwise, this should be the standard of care.
And the results are?
Results are awesome. The patients feel so good they don't even want to come back to remove their stents, and we have to keep calling them. It's time now, let's remove the stent because now this is not going to come back.
Well, that's the object, right? I mean, the whole theory behind medical care and healthcare treatment is to make the patient respect your knowledge because of something that you've done to mitigate their pain and the process of disease, correct?
Exactly.
Right. That's what we teach here at Nova Southeastern. You have to respect the patient. You may have all the capabilities you have and all the equipment you have, but if you don't respect the patient, because the patient eventually is going to tell you how successful you are.
Definitely.
Right. Let me just ask you, you said early on that you came from Pittsburgh. I don't know whether you were within the University of Pittsburgh process or otherwise, but they were preeminent in liver transplants in the United States, and I would assume that there must have been some major work done in the area of GI and the pancreas, et cetera, while you were being trained there, correct?
Definitely. So I went to UPMC for my residency, the medicine residency, and then I did my fellowship in Allegheny General Hospital.
Right.
And we did have a liver transplant center, and the work we do there is really like hardcore academics are really fun.
Yeah, I know.
I'm
that
really proud to be trained there. It's very good.
Yeah, I know that the liver transplant unit is at your sister hospital at Broward General, correct? If I'm not mistaken.
Broward General does have a liver
Right,
transplant,
that's
yes.
correct. Let me just talk to you again, Susi Justice. It must really be a real good feeling, as I said before, knowing that the investment of the management team, the executive team at Broward Health North to do what is now happening. They're regenerating a hospital that has been there for so many years, serving so many people, but they're changing with the needs.
Yeah, it's very exciting. I know the hospital's been there 50 years. I had my tonsils taken out there a long time ago. But it's a pleasure and it's a privilege to work with Dr. Gupta. We really enjoy learning new techniques. I mean, we have so many exciting things going on. This stent is just one of the newest things. But when Dr. Gupta came, she brought her EUS endoscopic ultrasound skills with her, and we got a bunch of new equipment and training. And the most rewarding is not only just working with Dr. Gupta, but to see how she helps the patients and how well the patients do. Because really, that's what it's about. You know, making the patient comfortable and giving them the most advanced care that they can receive.
Well, that's what it's all about. I mean, we're very proud of what we do here at Nova Southeastern. You know that we have soon to be eight colleges, and we have 36 programs, of which, you know, 28 of them have national accrediting standards, and we're accredited on every one of them. And I've always said that, our founder, Dr. Morton Terry, has always said that unless you respect the other health provider that you're working alongside of, then you're really not doing a very good job for the patient. So I would assume that this type of symbiotic relationship is something that you, that you
Our
enjoy.
nursing staff is like phenomenal. I think North Broward has the best nursing staff. Like, there is a lot of skills, and they're always willing to learn new techniques. So excited.
It is exciting, isn't it? Yes. So your husband is also a GI doc?
Yeah, we are both gastroenterologists, yes.
And his area of interest is not dissimilar to yours, or
He doesn't do the endoscopic ultrasounds, although he
Right.
was trained in it, but he just does the ERCPs, endoscopies, colonoscopies, and we do see like a lot of patients, Crohn's and ulcerative colitis in our office. So.
You know, we're down to the last 3 minutes of the show, but I got to ask this question because, you know, I was having conversation over the last weekend about trying to convince a nephew of mine to make sure that he goes back and has another colonoscopy because he's, you know, 58 years old, and he has had one colonoscopy about 3 years ago. They found some, you know, adenomas, etc., cysts, and you know, he's not paying attention to it. I mean, the doctor said, "I want to see you in 3 years." Tell me, is the doctor right?
Probably the doctor might have found some polyps,
Right.
and depending on what exact kinds of polyps they were, we do make recommendations. There are different polyps. There are certain ones are benign, which are mostly hyperplastic polyps, which are benign. And there are adenomatous or tubuloadenomatous polyps, which are more aggressive kinds. And we do recommend them to be followed more closely. If there was one polyp, we say they can come back in 5 years. If there is more than 2 or 3 polyps, we tell them to come back in 3 years.
And how much further did they go over a period of time?
If, say, colonoscopy was completely normal, and they are healthy, they have no personal history of any other cancers, and they have no family history, they can go as far as 10 years.
I want to thank you both for being here. Dr. Mayuri Gupta and your husband, who's not here, I want to thank you both for coming to our community and adding a new hyper-skilled dimension to the care for our patients. The wonderment of what I would call our community of South Florida is that even though we have technical borders, we don't have technical patients. They go from one area to another. And I know that you receive a lot of patients from all over Broward as well as Palm Beach County. So I want to thank you personally for not only your knowledge, but your skill and your care. So we're very pleased that you're here working for our people.
Thank you very much for having me
Thank
here.
you. And Susi Justice, I guess I'm a little biased because my wonderful wife is a nurse professional for many, many years. And I have great respect for the willingness of our nursing profession to gain new knowledge every single day.
That's true.
It's every single day, because every time you're in the OR and you see something that's perhaps a little different, in some cases dramatic, you learn something.
Yeah, it's a learning experience.
And you carry it with you, don't you?
Yeah, I do really think
Right.
it's a privilege to be a nurse. It's a privilege to work with the community and the patients and the doctors as well. And for the district, the North Broward Hospital, the Broward Health North Hospital District.
Yep.
So thanks for having me.
Thank you for being
My
here.
pleasure. Thank you.
And folks, I hope we answered some questions. You had some questions about, again, minimally invasive surgical techniques, but this was so special, knowing that Dr. Gupta came to us and is doing something which is not normally seen in every venue. And I just thought it would be a good opportunity for you to understand that at Broward Health North, you have Dr. Gupta doing this very specialized work. We hope that we answered some questions and we maybe stimulated your minds with some information about something that's new. Remember that both of these people work at Broward Health North, which is on Sample Road and I-95. And they're rebuilding the place, so I don't know what it looks like on the outside yet, but I know what it looks like on the inside. And as I told the hospital administrator, one of my hero of heroes is Dr. Murray Todd, and he was very instrumental in creating the Certified Stroke Center there, which has led the nation into a new venue of care. So I thank you for showing up. Remember, this is your show. If you have anything you want to ask us or tell us, there's an email address and a telephone number right here. And remember, as I always tell you, take good care of yourself. So screening is necessary. And remember, this show comes to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.